it's clear to me that of the four M's, the one that was the most, when we started this, what matters, mentation, mobility, and medications. When we started this effort with age-friendly, what matters was the most challenging element of the four M's. Clinicians, broadly speaking, especially geriatric care providers and those that cared a lot for older adults, were very familiar with reducing polypharmacy and working on medications. They were very familiar with the idea of assessing cognitive status and working on either delirium or dementia or depression. Familiar again with the contribution of mobility and functional status to overall patient satisfaction and life satisfaction over older adults. The part that was different and new for our clinicians for the most part was this idea of asking what matters, integrating the answer to that question into care plans, and then building care plans around what matters to older adults. And it's sort of counterintuitive on some level. It's the most human of the four M's, right? It's asking people how you're doing and what's important to you on some level. That's what it is fundamentally. And yet it was the most vexing because our systems were really the least equipped to ask that question and take the answer seriously. And that is what we spent a fair amount of time on. We actually developed a whole separate guide specifically to help clinicians ask the question of what matters to you, to our older adults, how you frame that, how you think about that, how you integrate that into care plans, et cetera. And in order for us to ensure that people felt confident and comfortable doing this, we had to also look at the evidence around what matters to you. And when you do work like goal-directed care or goal-concordant care, as it's sometimes called, or patient priorities care, as colleagues at Yale have called it, once you do that kind of work, you see this improvement in patient satisfaction. You see this improvement in quality of life, actually, in many settings, and you see in some instances a reduction in cost of care because now you're doing care that's more consistent with what the patient wishes, and in many cases, what the patient wishes is not for more, but in fact for less. So it's quite interesting to make that set of observations, and I think we're continuing to learn about this even now as we implement what matters to you. But I think this is one of the areas that has been the most, I think, striking and remarkable about the evidence review that we conducted, and even the implementation that we've seen since.